Let's talk about solitary acute intracranial hemorrhage, one of those core topics that shows up repeatedly in the FRCR2B exam. We'll go through it step by step, keeping the focus on how to recognize and differentiate each type based on imaging and typical causes. First, let's start with intracerebral hemorrhage. The two most important causes to remember are hypertension and cerebral amyloid angiopathy. In hypertensive hemorrhage, think about the deep structures. The basal ganglia, pons, and cerebellum are the classic sites. In contrast, cerebral amyloid angiopathy affects the elderly and tends to cause lobar bleeds. These are more peripheral and often associated with small, scattered microhemorrhages visible on susceptibility-weighted imaging. If you see multiple lobar bleeds in an older patient without hypertension, always think amyloid angiopathy first. Other causes of intracerebral hemorrhage include hemorrhagic transformation of infarcts, primary brain tumors like glioblastoma, or hemorrhagic metastases, for example from melanoma, renal cell carcinoma, or choriocarcinoma. Trauma can also cause intracerebral bleeds, but usually these are multifocal rather than solitary. Next, subarachnoid hemorrhage. Here the blood tracks into the sulci and sometimes the basal cisterns. The most common cause is rupture of an aneurysm, but trauma can also do it. For now, just remember, sulcal blood equals subarachnoid hemorrhage. Then we have subdural hemorrhage. This is most common in elderly patients after even minor trauma because of brain atrophy stretching the bridging veins. You'll also see it with intracranial hypotension or a dural arteriovenous fistula. On CT, the key feature is its crescentic shape. It spreads over the hemisphere but does not cross the falx. Moving on to extradural hemorrhage, this one's almost always traumatic. It's usually due to arterial bleeding, classically from the middle meningeal artery, though rarely it can be venous. It appears as a lentiform or biconvex hyperdense collection that does not cross cranial sutures. That distinction from subdural is very exam-worthy. Finally, intraventricular hemorrhage. This typically occurs due to extension from another bleed, either subarachnoid or intracerebral. A truly isolated intraventricular hemorrhage is rare, and when it does happen, it's usually because of rupture of a subependymal vein. Let's wrap up with 4 high-yield points to remember. 1. Deep bleed. Think hypertension. 2. Lobar bleed with microhemorrhages. Think cerebral amyloid angiopathy. 3. Crescentic collection, not crossing falx, subdural. 4. Lentiform collection, not crossing sutures, extradural. Simple patterns like these help you identify the type and cause of hemorrhage quickly and confidently in the exam.